Well, welcome everybody to tonight's webinar, which is, it's going to be quite exciting tonight. We're talking about rural and remote response to recent natural disasters, including COVID, but also what it's like to be a health professional trying to manage the complexity of what we're dealing with in the moment. So I'd like to start by acknowledging the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. I also think it's important that we recognise the trauma that these fellow Australians have experienced when their land has been devastated by natural disaster and pay our respects to elders past, present and emerging as they lead their communities towards recovery. I welcome opportunities to try and do two things at once, so I would really appreciate you putting up your questions in the chat box. You'll see right down the bottom of your screen there's a Q&A part there. Please feel free to toss up a question and I will make sure that as much as I can I read, respond and throw those to the panel when they get difficult. So I'd like to introduce our panel for this evening and just thank everybody for coming. And I'll start with me. My name is Louise Stone and I currently work in Canberra, but I have a history of working in rural and remote practice, and I've been teaching ACRRM's mental health programs for longer than, well, put it this way, when I started teaching mental health care programs for ACRRM, we were sending around distance education materials in large folders with cassette tapes. So there you go. It's been a very long time. I'd like to also introduce Sarah Chalmers. So Sarah has had an interesting history. She's been a remote GP based in East Arnhem Land and was working in the hospital and town-based practice and AMS and in various remote Indigenous communities and homelands. And now she's moved to Townsville and is trying the fly-in, fly-out experience while she also works as a senior lecturer at JCU. So hi to you, Sarah.
Hi.
And Sarah, I just wanted to ask, just to introduce yourself, you know, what's it been like, that move from the Northern Territory across to Townsville and particularly in the middle of COVID?
So the move was actually quite traumatic. So we'd been in East Arnhem for nearly 15 years. And in fact, I went out there on my own and left 15 years later with a husband and 2 children and, you know, a ridiculous amount of gear. Actually, the move during COVID, I think I picked a good place to go. So Townsville actually didn't see a lot of cases. The lockdown, I think, was fairly stressful, and I think for all the parents online, certainly the home-based teaching was particularly traumatic. And I'm now working out in Winton. So again, moving to completely COVID-free area so far. So I feel like I'm dodging bullets at this point.
But you certainly have come across plenty of disaster in your time, and I'll be flicking back to you in a minute to talk about coping with that when you're on the ground, particularly when there are very few people to help and you're in the middle of the melee. So I'll come back to you shortly. Now, Andrew, and we can tell who Andrew is because we've got a fairly X-chromosome dominant panel, but so hello Andrew. Andrew is the CEO of Western New South Wales Primary Health Network, and I had a look at his CV and he's got a background in local government but started his career in policy roles in New Zealand. But he tells me he also has an undergrad degree in agricultural science and he grew up in a property in New Zealand, so you've certainly got rural in your roots there, Andrew.
Yes, absolutely. It's pretty special, isn't it?
Yeah, and we were talking before the panel started that, you know, one of the things you've been thinking about is the nature of change and how change is continuous in this sort of setting. So did you want to make a few comments about that and your experience?
Yeah, look, thank you. I just thought it was more of a, you know, something to think about, and environment we live in is just so driven by change, and society changes so quickly, and to a certain extent over the last 2 months we've had to slow down. I know dealing with the pandemic has been frenetic for health professionals and people like us. But look, the reality is change in this country, certainly for rural communities. Economic change goes back to the 1980s and how small rural communities have been depopulated and the banks have closed. And often the only people left in town is the local shop. A lot of these communities have still have general practices. they have a school. But look, the rural communities have been facing change for many, many years. So I appreciate tonight is talking about COVID-19 and our response. But the reality is we have had to deal with it. And of course, in the context of Aboriginal people, dealing with it since colonisation. So really that's endemic in rural and remote communities. So I think it's important just to acknowledge that we've gone from droughts to fires to pandemics. It's just, and again, interestingly, no one has talked about climate change for 2 months.
Yes, I've certainly been aware of that.
And it's still there. And I think it's just important to acknowledge the impacts of change on society and rural communities, and how that's impacted upon people's emotional well-being. And that's, we all know that if you practice in rural communities, that's what you have to deal with, and but it's important to acknowledge it's not just one event. It's actually our society has been shaped by change, and just important to acknowledge that.
Yeah, and actually I'd be really interested if people are willing to, in that Q&A box, if people could perhaps type down a few words about what they think are the biggest changes that have occurred in their communities, because that will help us direct the discussion a little bit later on. So the Q&A box just in the middle of the bottom of your screen there. So Christine, welcome. It's wonderful to have you here. So Christine Morgan is the CEO of the National Mental Health Commission and the National Suicide Prevention Advisor to Prime Minister Scott Morrison. So she's a passionate leader in mental health care reform, and by the sound of it, very committed to listening and responding to the voice and needs of those with lived experience. So we're really glad to have you on, Christine. What have you seen have been the major changes in the last few months, particularly with respect to rural and remote Australia?
Yeah, it's a really good question. And I think, can I pick up actually on the tail end of what Andrew was saying, because I think that was just so pertinent, what he's saying about the fact that change is, in a sense, one of our constants. But Andrew, I think one of the things that we've certainly been really conscious of is the magnitude of the change. So the magnitude of the drought was, that kind of worst we've had in a generation. The fires were incredible. I think the fact that we had it across so many of our states and territories, and it required both a federal response as well as a state one, and then COVID. So I think it's the rapidity of that, one on top of the other. And the sense of change that I've had, Louise, is been around the sense of, oh my goodness, we've never had it so big. And oh my goodness, we're in uncharted territories. So change is to be expected. Coping with natural disasters is something Aussies do. But when you have it of the magnitude we've had with the drought, with the fires, and now with COVID-19, I think it's that cumulative effect has been really interesting. So that's certainly one of the things we've noticed. The other thing that I think from a system perspective, and I'm always really interested from the Commission looking at how does our health system work, particularly I've got a real interest in how it reaches out into our Indigenous communities and how we reach out into regional, rural, remote Australia. And so I think one of the big things that I have seen over the last few months is the absolute shift across to reliance upon digital services. So all of our support lines and helplines and other sort of organisations have really been amping up in the digital space. And then, of course, we've also had the telehealth changes. So I think it's the magnitude of change, it's the fact that everybody is uncertain as to where this all leads to, and then us all connecting in quite different ways, particularly online. And I think in that space, having to acknowledge that not everybody has equity of access when it comes to digital services. And again, that's a real challenge. So some big things happening, I think.
Yeah, I did a study a while ago that suggested that the average reading age, or the lowest reading age of any of the digital health services in mental health, was above that required of Great Expectations. So it's certainly never mind having internet, phone credit, ability to access a computer. One needs to be reading English at the level of Dickens in order to be able to read some of the things that we're providing. So I guess that's a really difficult space for us to consider. I wanted to think a little bit about what some of the participants are saying in the chat box here about, there are some people in the mid-zone who seem to cope with constant change and adapt. And then, of course, there are people who who don't adapt as readily. And I just wanted to share, I guess, a little of my experience, and I'm providing telehealth, mental health, broader than Canberra, across Australia, certainly with doctors across Australia. And I just wanted to share, I thought about my last 5 patients, and I thought I'd share my last 5 patients to sort of give you a feel of the sort of diversity that we're seeing. So the last few days, I've had a 90-year-old who's suicidal due to loneliness and chronic pain, being stuck in a nursing home and unable to be distracted. I've got a young woman with borderline personality disorder and major depression who had a major setback because of the suicide of a friend. A 60-year-old multimillionaire executive who is now broke and facing homelessness due to the economic shutdown. A carer of a child with severe autism who now has no social supports, no schooling, and is really at the end of her tether trying to manage him and her other children doing homeschooling. And a young man with substance abuse and a history of childhood trauma and a background of depression that's become increasingly affected by what looks like mania. So I think one of the things that we're finding is that there's an extraordinary diversity in the presentations across the board, and it's not just more of the same. We're not looking at more depression, more PTSD, more anxiety. We're looking at that broad scope. So I just wanted to talk to you, Sarah, because you've had the experience of living in an Aboriginal community that has experienced natural disaster, I assume, up there, but also you've had other disasters land on your community while you've been in there. What's it like being the one rural generalist in such a large community with such deep needs?
So I guess I think about, I've had 2 really quite intense sort of disaster type experiences. And one of them was when I was still a registrar, but working solo in a remote, so it was like a homeland, so fly in, fly out services to the really, really remote communities across East Arnhem Land. And we had the Northern Territory emergency response, or the intervention, as we talked about it, which was really, really quite intense. And certainly, there were lots of experiences as a doctor and trying to manage people's responses to what was happening to them. But it was probably one of the few times in my life where I've actually been really ashamed to be a white person and walking around in a community feeling that, the things that we can do to people, really, really damaging. I think at that time, as not a very experienced practitioner, I didn't actually have the experience, and I don't think I actually had the courage to, when talking to people about what was going on, to really try and find out about their mental health. I think we were so busy talking about the effect of, the social changes and the unfairness. So actually talking about, and, I guess also acknowledging the fact that a lot of people don't speak particularly sophisticated English. And my Yolngu Matha is terrible. So actually being able to talk about some of those deep concepts was way beyond my capacity at the time. And my other experience, luckily for me, I wasn't the only doctor involved. I had moved back into town, into Nhulunbuy, which was about 3,500 people at the time, but we actually had, the shutdown of our refinery. So around about 1,000 people, about 3,500 people, found out that they would be losing their jobs. And it got outed by the media. So there was no softly, no nice approach to it. It was just 1 minute, everyone was wondering exactly what was going on. And the next day it was on the front page of the Australian that our refinery was shutting down. And because of the remote, the remoteness of the community, it actually took a full 12 months to move all of those people out. There are only so many packing trucks that you can get into town. They can only pack so many houses at a time. And the mine was also, it was done in a sequential way. And so people were let off as their phase of the mine was shutting down. And I mean, I guess the difference between those two experiences for me as a clinician, I mean, it was very much about maturity. I think I was, by that stage, that was another 5 or 6 years later, I had a lot more experience and, as I said, a little bit more courage to, when people came in, because nobody came in saying, I can't cope. It was, I've got a sore knee. Well, why have you got a sore knee? Well, I was out running. Is this a new thing? Yes, it's a new thing. Why are you out running? Well, because I can't sleep. I was running at 4 o'clock in the morning and I tripped over something in the dark. So then, you deal with the knee, but actually it's about, so tell me a bit more about not coping. So that was a really stressful time. So we had done things, we didn't take on new registrars. We didn't take on medical students into the practice. And so a lot of the extra help that we would normally have had, we didn't have. We also didn't realise the impact of what it would be like. So it was really difficult, actually. It was very stressful. We had long, long days of, every single person who came in would have, really awful and really sad stories about their own experiences in losing their jobs and having to move. Lots of people had lived there for a long time, and the loss of control was, really hard for them to manage. And I guess for us as clinicians, so there was myself and another FACRM in the practice. We did have a couple of registrars, and we had a hospital, with rural generalists and things who we could talk to. But ultimately, the way that we managed through the process was that we looked after each other, and we would have big, long days, and then we would sit and talk about all of the things that happened.
Look, it's really important, I think, to recognise the trauma on the whole community and that we are part of that community. When I trained, I think I was still in the era that believed that vicarious trauma was for weak people, that, if you had good enough boundaries and if you managed things appropriately, then you didn't experience vicarious trauma. And we know now that that's rubbish. We know that. I have a wonderful photo of a golden retriever who's asleep on a little sleepy baby, and it always reminds me that, feelings are contagious, and fear is certainly contagious. We've had a couple of people write up on the Q&A there about the whole town having this infectious feel of anxiety, and as the GP or generalist in the middle of that, it's very hard to wash that fear off. It's like you have to wash that off at the end of the day, like you wash everything else off at the end of the day, because it does get to you after a while. Yeah. I want to go over to Andrew for a minute and talk a little bit about the PHN's role with that, Andrew. You must be in an environment where the PHNs are trying to support the health workforce in Western New South Wales at the moment. And what are some of the strategies that you're trying to implement to try and support isolated doctors and remote nurses and allied health professionals to try and help them adapt to this world where there is fear, as you say, fear on fear on fear, drought and then flooding rains and then COVID, probably a plague of locusts, although I think they're in Ethiopia. So what are you doing, and what have you seen other PHNs doing to try and support their workforce?
Look, I suppose it goes to the centrality of general practice to the work we do. And I think that, as you said, the support that we provide through a whole range of activities we do, particularly education, and that's certainly one of the things that we as our PHN has had a big focus on. And if you give people the tools and support, they can carry out functions themselves. So that, to a certain extent, that's what we've done. And of course, as a commissioning organisation, we rely on other providers in our community to do the work for us, and it's about ensuring that those providers have things like longer term funding arrangements. And I think this environment, unfortunately, the environment that we've faced has been a lot of short term funding, year by year funding, and you can't hold a workforce in rural communities. People don't stay, people leave. So one of the messages for us, of course, is about longevity of funding. And I think we're working towards that. So that's a positive sign. If we can actually give our community, our health workers, in our communities, longevity, we can build their capabilities, we can support their training, then we can build it in our communities. The other thing we've done, of course, is around the collaboration that we work very closely with our local health districts, local health networks in our region, and I think that's a hallmark of our work. Look, in the context of mental health services, we've still got a long way to go. No one's questioning no one's saying that we've landed whatever we've landed, but I think what we're saying, there are some building blocks in regional communities around people working together, and I think that's probably one thing that we have focused on in Western New South Wales. And some of our work around planning and things like that. The other thing we've focused on, and because our 10.5% of our regional population identify as Aboriginal people, we as an organisation have focused around Aboriginal health services and Aboriginal mental health services being delivered by Aboriginal organisations. So, there's certain strands that we all do. Each PHN is different. And look, I certainly can't speak on behalf of other PHNs, because some have run suicide prevention trials and are doing, have had some very good results around that. In our context, ours is focused very much around community capacity building. And the challenge is when government money goes in and government money finishes, then what? And as we know in rural communities, we don't want to set services up to have to close them down. So actually building capacity in those local communities is something we've really focused on. So yeah, again, general practice support, collaboration, regional collaboration between health funders, the work we do with the Aboriginal sector, and also the work we do with communities, individual communities, around helping them build their own capabilities, and certainly, like a peer workforce, those things like that, which they've got to last the test of time. And people get burnt out by government funding coming and going, and GPs in particular just become a bit desensitised to that sometimes. Yeah. So those are some of the things we've been doing.
And PPE. The vexed question of PPE.
Yeah, well, one of the things, well, certainly in terms of drought funding, we were one of the regions that received drought funding, and and the challenge is, what do you, it's a short-term funding horizon. What do you do to build things in our communities that are going to last in a mental health context? And so I think it's a real dilemma when government comes through with programs that are not long lasting. How do we ensure that we use those funds, that they are long lasting in our communities? And that's one thing that certainly our region's take sort of a focus around.
So that brings me to you, Christine, and I feel a little bit like the Brady Bunch here because I've got little squares in front of me, but anyway, there you go. Christine, I just wanted to ask you, as we move towards that, longitudinal government funding, we've been working with many doctors at the moment who are experiencing significant vicarious trauma, and also obviously personal trauma. Their houses have burned down with the rest of their communities. They are exposed to COVID and to a higher degree than the average person. And I understand that the Morrison government has committed to providing resources for healthcare workers needing support. So I just wanted to ask you a little bit about that initiative, but also to, in part of that response, to talk about that question of, is this another aliquot of government funding which is going to disappear? Is it another silo? How can we make sure that this continues and is integrated into long-term care for health workers? Because I can't see any of this trauma going away anytime soon.
That is such a good question, always such a good question. So in terms of the actual service, it was one of the components of the package that was announced at the end of March. So 31st to 29th of March, 30 March, somewhere around there, we announced the $74 million package for mental health targeted services. And that was also part of a much bigger announcement, which included the change across to telehealth services for mental health service delivery. So what we tried to do in that package was actually take a bit of a preventative approach and say, we anticipate that the impact of COVID-19, particularly when you look at it on top of the drought, the bushfires, etc., is going to affect many, many people. And so we looked to amp up a general support service, firstly through Beyond Blue, but then we started to look at particular groups where we thought there might be needs that were quite specific to those groups. And one of those that was top of the list, in fact, was the mental health and wellbeing of our frontline workers, and particularly our healthcare workers. So the funding there has gone to the Black Dog Institute, who have established what they're calling 10, which is the Essential Network, which provides a whole range of resources and interactive capacity to really focus in on those things that frontline workers are facing, which could have a really significant impact on their mental health and well-being. So that is a general comment, and I would encourage anybody to hop online and to have a look at what is being provided there. But over and above that is this really critical question of what are we doing long term to look after the needs of our mental health workers? And look, a couple of things there. Firstly, picking up on what Andrew has said, I think a lot of this is focusing in on capacity. And capacity is not just numbers of workers, but it's actually how do we ensure that we're looking after their well-being and ensuring the sustainability of what they do? How do we ensure that they're feeling professionally supported, appropriately supervised, that they are receiving the supports that they need in a very general sense, and recognizing, I think, most particularly, and I think, Sarah, you were making this point, people come in, and let's say they come in to see you at a general practice level, and they don't actually say, I am challenged with any mental health issue. They say, I've got a sore knee, and this is what I've been doing. I think when it comes to those of us who work in mental health, if for some reason it seems sometimes particularly difficult to admit to the fact that we actually need some help ourselves. And I think that challenge, certainly in times that I have been interacting with rural and regional communities and remote communities, it can be one of the most difficult things is actually trying to reach out for help. In fact, I recently did a connections tour through the Commission, and I was in a regional area of New South Wales, and we had a very small meeting of health professionals. And we all kind of shared with each other the fact that when we needed mental health support, we actually went out of town to find it because we didn't want to actually carry that sense of exposure in the place where we were delivering services ourselves. So I think one of the issues when it comes to how we maintain capacity, certainly funding is a big thing, but I think funding follows real clarity of understanding about need. And I think what we need is this. If I look across the spectrum, there's the challenges of sustainability of workforce in rural, regional, remote areas. And Andrew is just saying, how do we help people stay there longer? How do we ensure their capacity in terms of supervision, etc.? How do we reach out and meet their needs, and particularly their mental health needs, right across that spectrum? And I think the final thing that we're really trying to focus in on and get a deeper understanding of is the breadth of health and allied health professionals who work across mental health. Mental health is such a broad topic, 2 words that describe just so much. So they're really fundamental issues. I think the best way to try and maintain that funding support is for those of us who are working in this space to keep it a front and centre issue. And we can't do mental health without our health and allied health professionals. It's a foundational need. We must keep it at the forefront.
So Sarah, interestingly enough, if you were up in Arnhem Land and you wanted to do an aesthetics training, you'd be eligible for a procedural grants program, or if you wanted to do surgery, you'd be eligible for a procedural grants program. But if you wanted to do psychiatry, you'd have to do it on your own and pay for it yourself. Do you see that it can be somewhat challenging to develop the skills? I know this is a leading question, but I'll give it to you anyway. Is it somewhat challenging to gain the breadth of skills that you need in order to conduct the sort of work that was extraordinary that you were doing in some of the most difficult communities in Australia in terms of health? And what do you think we can do to try and address that? I'm hearing from doctors who feel that they've been very much thrown in the deep end with very little support. So I'm curious about your perspective on that.
Yes. So yes, it's very hard to get the training that you need. I must admit, when I was asked to be on the panel, I was thinking, well, where are all the good people? Because I don't have special skills, and I certainly didn't. I've got much better ones now. I feel like I could run a really great webinar on how not to manage, your community and yourself through these processes. Like we certainly made a lot of errors. I guess one of the things about it is that, as rural generalists, we train in these sorts of environments, and without, I mean, yes, obviously it'd be great to have proper, specialised training, but actually we train to manage things that we don't know how to manage. And we do the best that we can, and we know that, well, we need to know that, even when we are on our own and we don't have special skills, we've actually got a whole lot of skills that will provide some assistance for people. So, I would say to everybody who's out there and managing communities who are, really struggling, and, obviously as the GPs in town, everyone is struggling as well. I think that was one of the big differences between the two circumstances that I was talking about earlier. One of them, the trauma was happening to somebody else. It was pretty stressful, but I was okay, and I could, and that was much easier to manage. But as you've mentioned, Louise, when you're in the middle of it all, you're experiencing trauma as well. There were some points in there about, being able to ask for help. That was one of the things that, myself and my practice partner said to, people afterwards. Why didn't you help us? And they said, we didn't ask. And we didn't, we were, when you're right in the middle of it all, that's the last thing you think of. You're too busy thinking about, oh my goodness, is that last patient that I saw today, is that the person that's going to go home and commit suicide? And am I going to be held responsible for that? So when there's all of that stuff, as well as, am I going to lose my job? Am I going to get kicked out of town? That's a whole lot of stuff to think about, and to actually put your hand up and say to someone, hey, I'm so not coping. It didn't even occur to me.
It's interesting you say that, because I think that in the last 10 years, there's been a real shift to automated provision of support through digital mental health services of all sorts. If the digital mental health service had been there, would you have gone there? Or do you, I suppose I'm trying to ask the question, are we hitting the mark with providing resource, website-based, protocol-based services? Or do you think we need people to talk to people?
So I was going to say to that, the idea of ringing up a complete stranger and saying, I'm not coping, that was never going to happen. And to be honest, I don't think that I actually realised how, badly I was coping. I think I've told people afterwards, in the middle of it all, my husband, who's a builder, came up and, just said, your behaviour is appalling, and everyone in the family is just, we hate you because you come home so late and you're grumpy and you're unpleasant and you need to get help. And I was like, you're a builder, what would you know? But really, he's right. Sorry to all the builders out there. But again, it's like, that's that whole thing, you can't see the forest for the trees. You don't, and it is so very overwhelming, that feeling of being out of control, and all those emotions that go with that, and being able to recognise, so first of all, recognise that you have a problem, and then talk to a complete stranger over the phone. No. So mentors, people that we know, they're the people that you want to talk to. And so and I don't know the answer. I don't know how we manage this, but I know that, and I'm sure it works for some people, but it certainly wasn't, what we needed at the time.
I just wanted to put in a plug for a few organisations in there. You probably know the AMA Doctor for Doctors website and the Beyond Blue program, but the doctors health advisory services, which are available Australia-wide, free of charge. Depending on your state, you might be able to access them if you're a veterinarian, not just a veteran. And also if you're a medical student or a dentist, it just depends where you are, whether that's accessible. Many people don't know about the Medical Benevolence Society, which is an organisation that is prepared to give small financial gifts. And certainly for doctors who are struggling, particularly with finding registrars who haven't got work, I think it's very difficult to survive. There are people who use bayonet groups for this sort of work to get together as peer groups. And certainly the one blessing of telehealth is, and I'm involved with a large group who are providing consultations for people around the country by using the telehealth item numbers, which have been a complete gift, because you can suddenly talk to a GP who's not in your town, who doesn't know you, who isn't your partner in the practice, who doesn't, you know, and having been in a small remote, small rural community when I was young, you know, it's very difficult to talk to your partners about things. It's interesting, we all say, you know, oh, no, you shouldn't have any stigma around mental health. But if I ask you how you'd feel in the waiting room if you're coming to talk to me about depression, most people would say that that's really, really challenging. So I think, yeah, that relational stuff is terribly important. Yeah, Andrew.
Look, I was just going to, the other component that we face in small rural communities is the capacity, if you're in a, you know, to actually take a break, to take leave.
Yep.
So if you're the only GP in town, you can't let those, you know, those people just so dedicated, can't let the community down.
That's
Who's
right.
going to replace them? They need to take a break.
Yep.
And particularly over the last year or two. So that's certainly that's a piece of work that we've been working with, say, Rural Doctors New South Wales on, around trying to have some sort of backfill arrangement for these small towns. So that's a really good, that's something that's come up. People just can't take a break for their family.
Yep.
And Louise, can I just say there too, I think that's really important. Just going to your point of stigma, it was fascinating. I had an opportunity, as I mentioned briefly, to go around Australia into 26 different communities last year, and we were asking the question about mental health and what were barriers to seeking help, and you know, those kind of questions. And awareness about mental health is really high right around the country. People get it, they understand it. We can have these kind of conversations. But oh my goodness, when it comes to what would stop you reaching out for help, and it included health professionals, but right across the spectrum, stigma. And
absolutely.
And it's interesting, it breaks down, we think, into three different sorts. There's the self-stigma, the self-shame, that it's okay that you can't cope, but I should be able to. And I think particularly for those of us who work in mental health, we kind of feel for some reason we need to be able to do it. So that's the self-stigma. There's what we call the attitudinal stigma, just the general community feel. And I think that's particularly high, unfortunately, around suicide and suicidal behaviour. And then there's the real structural stigma. And we certainly heard, for instance, for health professionals, what is the consequence for me if I disclose that I have mental health challenges? How do I professionally deal with that? And what is the impact of me on that? Now, they're not easy questions, but until we really grapple with those, then it is extraordinarily challenging, not only to overcome, Sarah, as you say, our own kind of, we're down in the bulrushes and we don't even see it and we just have to keep going. That's a real big challenge. You'd want somebody you can talk to. It's another challenge. But when there is real stigma associated with it, then we've got a really deep-seated problem that we need to work with, I think, right across the system to say, what are we going to do about that?
Yes. I'd really like to pick that up. I'm going to step out of my role as coordinating and just say some stuff because it happens to be in my head. But, you know, we know from the Beyond Blue survey of doctors that there is a 4% suicide attempt risk across the spectrum of doctors that were surveyed. So 4% of the doctors who were surveyed had attempted suicide. That's incredibly high, compares to about 0.5% of the general population. We also know from some studies that 98% of female and about 80% of men in physician traineeships experience vicarious trauma sufficiently to be distressed. We know that about 60% of doctors will not disclose their mental health conditions because they think it will have a negative impact on their career and they think they will be perceived as being less competent. So, you know, in that sort of world, it's no wonder. I will say that I'm not speaking on behalf of the board, but I do sit on the ACT Medical Board, and I will say, as I always do to my patients, there is no reason, zero, zip, zero, completely zero, that if someone has well-treated mental illness, they cannot function in their normal roles. There is no reason to evoke the board. It is not the board's responsibility to make sure that every doctor is spiffingly clean and healthy at all times. It's the board's responsibility to protect the public. If a person is practicing well, there is absolutely no reason. So I'm always tell my patients that up front, and I would encourage you, if you ever see your GPs, to ask their position on the board, because it makes you feel more secure if you know that a doctor can come out hard and say no. Unless you, actually it's very difficult because you've got to actually observe a person in practice, which by definition, if they're in your consulting room, you're not doing it anyway. You can't report a person just on what you reckon might have happened in the hospital from what they just told you. So, you know, on balance, I think we need to be a lot more proactive, particularly for the junior doctors and registrars in our care, because they really struggle. I've just been watching some comments, and I had a little question there about imposter syndrome. And Sarah, you just gave us the most perfect, I mean, I just look at what you do and I'm absolutely awestruck at what you've managed to achieve up there in really difficult circumstances. And yet I've heard that little glimmer of imposter syndrome running through your veins. Is that something that you see a lot in other doctors?
Yep, lots.
And why? Why do you think it's so? And what do we do about it, Sarah? How do we continue to do good work even when we feel that one day someone's going to find us out and realise we're screamingly incompetent and we're just putting on a really big act?
Yeah, it's support. And I guess, you know, one of the things I was thinking of before, you know, when, you know, because we all work in different communities across the country, and you know, we sometimes talk about regional, rural and remote. You know, they're not comparable. They're very, very different contexts. And you know, having worked recently in a few different places, so you know, a few different places around Arnhem Land. I did some work in Tennant Creek, did some stuff on Palm Island, and now I'm out in Winton. And absolutely that old phrase, if you've been to one rural community, you've been to one rural community. And the same thing with doctors, you know, like the support that might be required for, you know, a doctor who, you know, whose town burnt down and lost their home and, you know, was trying to look after their community is not the same support that's required for, you know, the doctors working on Palm Island and, you know, people out here. So I've learned lots about, you know, people coping in the drought and things over the last 3 weeks, which is something that I've never, you know, I've never had conversations about the drought before because, you know, we have the wet season. The only drought is, you know, during the dry season. So I really think that, you know, support is a really important part of it, and we can get it from lots of different places. And we need, I feel like we should be able to have programs where we can support, I guess, choose the type of support we have. So do we want it through our college? Yep. So there's something. Do we want it through the professional organisations and the PHNs? Well, you know, there's another way to do it. Do we want, you know, highly trained doctors for doctors? Yep. So there's another way. It's, you know, I think everybody does things differently, and it'd be really good to see a whole suite of things that were, you know, put in place to help and for the long term. So, you know, this idea of short-term government funding, you know, I was asking people today about some of the services that were provided after the floods out this way last year. And there was an amazing service provided, except that it was for, you know, 8 weeks at a particular time, and it was provided too early. And by the time people were, you know, at that stage, people were too busy trying to get their properties back up and running and things. And by the time they actually needed the support, it had gone. So those sorts of things, you know, we need to plan properly and for the long term. And there might be people still upset by a particular event that happened 10 years ago. And, you know, that should be okay.
I wanted to move slightly sideways, Christine, and ask you a question. And I might be putting you on the spot, but certainly in my practice, I'm seeing perhaps not an upsurge in the frequency, but an upsurge in the severity of domestic violence. It always was pretty frequent, but now it's getting to be more of an issue. And I'm finding, particularly with my patients who have significant physical disability, not being able to get away from the abusive partner, the kids, the levels of stress going up, the kids not being at school, the risk is growing. And I'm wondering, I know I've seen quite a bit of work on PTSD and depression/anxiety, but I haven't heard much about a response to domestic violence in this sort of setting. And I'm just wondering if you had anything to say about that.
Great question, Louise. Great question. The answer is yes, it is very much on our radar. We're keeping that and the suicide risk as being really, really high, antenna raising kind of issues. And in fact, in the March response that we did for the COVID-19, there was about 150 million that was included in that for domestic violence and to try and provide additional services to our 1800 respect number, but also to our men's line. And so looking at kind of both sides of the equation. Sitting behind that, they're just the bits we've provided. Sitting behind that, there's some really concerning things we are seeing. We are seeing quite a significant increase in calls through to 1800 respect. So we are getting those, and we're getting significant increases, about 34-35% increases in web chats to 1800 respect. So that's telling us something. The police are reporting significantly increased breaches of AVOs. So we're seeing increased levels of violence, and we're hearing quite a lot of anecdotes about it in the home. One of the things, though, that is particularly concerning us, and we may see a change in this as we ease some of the restrictions, is it is relatively straightforward to envisage in a pressure cooker environment at home the risk of increased violence. We can get that. But what also is happening in those home environments is that it's usually women. So let's face it, it's usually women and children. Women are feeling increasingly, I can't get out. I can't get out. It's not safe for me at the moment to go and find an alternative. There is nowhere else I can go. And most importantly, I'm here to protect the kids. So there is a lot, and that I can't readily go and get that help. So I can't just, so just trying to be able to get behind that, and certainly in talking with domestic violence and family violence groups, that is a real concern they have at the moment, that it's there. We're seeing signs of it bleeding out in terms of increased rates of violence in the community. That's coming through from the police. We are seeing it across that board, and we are seeing men increase. This is the other interesting one: increased access to service from men who are saying, "This is how I'm feeling, and I don't want to do it. So what do I do?" So absolutely, it's an issue, and we have to stay so alert to it.
Yeah, and I guess I'm assuming that shelters are closed. I've never been able to get a patient into a shelter in Canberra anyway, because the options are very low, but I'm assuming that there is no option at this point because of COVID. I think
people are certainly looking at what are some other options we could provide for people. But I think it's that accessibility, and I think the call out we've been making is for people to be really alert. I think this is one of those times where we do need to reach out and we can't make assumptions, but at the same time, if there's a sense of unease, then it's better to make some form of inquiry than to just let it go.
Yeah. Andrew, I wanted to go back to you to talk a little bit about geographical isolation, because one thing we know is that the rates of mental illness and suicide rise with geographical isolation and low socioeconomic status. And yet most mental health services go to the richest and most urban quintile of the population, including e-mental health. So I'm just curious how we go about trying to address that imbalance, because it seems that the more services we throw, the larger the discrepancy and the larger the disadvantage. And I know from Sarah's point of view that certainly the services that we would be proposing in Canberra are unlikely to work in Arnhem Land. So I'm just wondering, as a PHN, given that you're commissioning services, how do you make sure that those services are distributed fairly as equitably as they can be?
Well, that's the $1 million question, I suppose. And we...
Is it only $1 million?
Oh,
I think it's slightly more for the PHN.
$1 million question in a little town. In a little town. Let's just talk about one of our little towns. Look, I think it's one of our dilemmas, and I just talked about, you know, the funding paradigms and all those sorts of things in the past. I mean, we certainly have increasingly put emphasis around telehealth as a means of accessing services in small communities, and so our sort of the hard to reach service that we fund is using telehealth as a mix, obviously face to face, and that's through our service provision. And obviously the recent changes with MBS and the access to telehealth services, I mean, certainly that's certainly, there's no question that's making, well, we believe it's making an impact. We haven't seen the data yet, but we know that the support that we've provided to general practices in terms of digital platforms and things like that hopefully will come into play. The other one is around, of course, is alluding to Aboriginal social emotional wellbeing programs, and again, that's a significant part of our population, and that has been about building capacity and archos around delivering social emotional wellbeing services, and that's some, you know, generally non-clinical services as well. So I suppose we've just tried to work with the different communities as best we can, trying to ensure our service providers are retaining staff and building capacity in their staff, giving them the confidence about funding. You know, those are the sorts of things that make a difference. But certainly access to, certainly digital services. We know the digital divide's a challenge in lots of communities. But look, increasingly that has to be part of the mix of service provision. I mean, that's just the reality. So again, I'm not saying we have the answers, but I think it's about tailoring our services to the needs of individual communities, and certainly Aboriginal communities in particular is something that we've given some emphasis to.
I wanted to go to you, Sarah, because we know that one of the biggest predictors of burnout is moral distress. And moral distress is this concept which comes up, which talks about the feeling that you get as a provider when you know what the right thing to do is, but you're unable to do it, either because the system won't allow you, because you're overloaded, because there's too much going on. That sense of not being able to work to your values. And how did you deal with that? You were in a position, you said, where, you know, you were feeling a little bit ashamed of the position of Australia on an issue in a community, and you were having to work within that policy, which is really hard. And we often get in that position where we don't have the resources we need to do the job we know we can do, but we're stuck. So how do you deal with that as a clinician, and what advice do you have to the people doing their first disaster? You said this is probably your third. What advice do you have?
I guess one of the things that I remember, I mean, during the intervention, so that stuff, that was really tricky, but so the way that we managed our through that was I worked in a really, really good team. And I did think at the time, and, you know, on reflection, it was a little bit easier again because it wasn't us. And so, you know, although we felt, you know, we felt like we were in a system that we couldn't change, actually there were some little things that we could do. And so, you know, it just so happened that we were so remote that none of the service providers that were put forward through OATSI, you know, wanted to come as far remote as we were. So actually we got given the cash ourselves, and, you know, to do the child health checks. And I don't know if I should be saying this in public, but we, we made show bags for the kids, and we gave them books and stickers and colouring in things. We took lunch out to a community, to feed people who had really low food security. And we made the focus about health rather than, and to try and change things. So that felt a little bit easier, and it was a bit cheeky too. I think that helped. I think one of the things, through the mine curtailment, as you say, you feel, we felt like we were bad doctors. We were dealing with people. We didn't do any chronic disease care, because everybody who came in took up all of our time talking about, the difficulties that they were having in managing the process. And I think I already mentioned, the way that my practice partner and I managed through was, so first of all, we both had amazing partners they got together. We didn't know it at the time, but they got together and said, these guys really aren't coping, so we're going to have to pick up the pieces. And they, shared the children between them so that we would, that we'd get time to relax after work. They'd make dinner, we'd have dinner parties together, and they'd try to make things as normal as possible. That really helped. They didn't let us drink too much, which is actually what we wanted to do. That's, often, I don't know, maybe I shouldn't say that in public, but, that's a really obvious coping mechanism, and everybody else in town was. So, it seemed an obvious coping process, and our partners said, no, you can't. You won't be able to go to work tomorrow. And I guess the other thing was we looked after each other. So, as I said, we had debriefings almost every day. So we'd finish up with our patients at 5, we'd have 3 or 4 hours of paperwork afterwards, and then we would make sure that we sat down together and talked about what had happened during the day, and we made plans for how we were going to look after the other practice staff. So we didn't feel like there was support coming from elsewhere, but we provided it for ourselves. Again, we felt like we weren't doing a very good job, but actually we did some really clever things. And I think, again, because both of us had really, developed all of our clinical skills in those remote places. And so we just managed, because that's what you do.
It's interesting. I've just written an article on coping theory, and you've just raised a few of those strategies. So coping theory would suggest that you go through 3 phases. You start with a very honest appraisal of the situation and understanding. And I think doctors are in a great position to interpret the evidence and the non-evidence and the false evidence and actually understand what the disaster is. And then, you have problem-solving strategies, which we're very good at, and emotion-focused strategies. And we tend to be, as humans, will often use emotion-focused strategies that are unhelpful. So alcohol, anything to help us avoid alcohol, workaholism, being on YouTube and watching cats all evening, anything that is going to distract you from having to think about the problem. But of course, there are the positive ones, which are things like exercise and mindfulness and yoga and so on. But I think the difficulty with COVID, and just coming back to COVID as an exemplar, is that a lot of it is unfixable. It's an invisible epidemic. It's not like a bushfire that we can see coming over the horizon. It's a constant threat. And because it's invisible, it's difficult, but also it drives us apart. Most disasters bring us together. We come together to face something. We meet in the local hall and have a barbecue and work out how to get food to the people whose houses are burned down. With COVID, we've separated people, and that is a real problem, because when you can't fix something, distraction, connection, and a sense of doing something with meaning and purpose are terribly important. And I think if we can bring in those ideas of ways of helping with distraction and connection, and also that sense of self-efficacy of trying to help people find something to do that matters, trying to support others, for instance, I think that makes an enormous difference. So I'm sorry to take everything you said and put it with theory, but you just gave me an entire theory in a list, and I just thought, oh look, I'll give you the names around the traps to try and tie that in. I'm curious, Andrew, you've got healthcare workers in your footprint, and one of the things that we struggle with as health workers is that we usually get the unfixable problems and what we call the missing middle, the really serious, well, the patients with psychosis and definable diseases get seen by acute mental health. And the patients with mild to moderate depression and anxiety, if they've got high enough literacy, can use e-mental health strategies. If they don't, there are some affordable strategies sometimes, depending on where you live. But there's this enormous missing middle of highly complex patients who really have nowhere else to go but us. And I'm curious, you know, PHNs provide education and support, and what strategies do PHNs use that you've seen around the country to try and bolster the GPs who've got these multi-morbid, incredibly complex patients, including patients with, you know, long histories of trauma and some patients with, you know, personality issues or autism that are not managed well by either acute mental health or the low-level stepped care that we often have access to?
Look, one service that we have, we along with other PHNs in New South Wales and now in other parts of the country, co-funding is a support service for GPs. Just the sort of thing you're talking about how do I deal with this person's condition. Look, it's a great addition, and we've had good feedback, really good feedback from GPs who actually need to know where to go to get advice about certain condition that their patients are facing. So look, that's an example of us pulling resources together. It's sort of really a helpline for GPs around getting, and again, the feedback comes quite quickly. So it's a really, you know, you pose a question, it comes back, and from a specialist, and they can actually deal with that. So I think that's a really good example in terms of helping a GP deal with a particular condition in a really quick, smart manner. The other component, of course, is more regional, and that's where we put a lot of work into sort of aligning the system. This whole issue of fragmentation, how disjointed sometimes the system is, as you know, as GPs well know, when they're trying to refer a patient and there's no one to refer a patient to. So that has to be that's a big focus of our ongoing piece of work around how we join up state and Commonwealth funded services at a regional level and have better alignment so that people know referral pathways and they know that they're going to refer somebody, that's somebody there to look after them. And I think that's where GPs get pretty frustrated when they actually, you know, people just disappear.
Yeah.
So those are two things. Certainly the support line for GPs with a sort of psychiatry, you know, issues and stuff. So that's about giving that, you know, feedback and advice to a GP, and then clearly that whole regional work that we have to do to better align our funding.
Yeah. It's interesting that when you talk about that, that's the old GP psych support that was so incredibly helpful and that was defunded some years ago. It's really great. It's come back up in New South Wales. So for those of you not in New South Wales, the New South Wales PHNs have banded together, and there's basically a helpline. You can write, email, ring, and a psychiatrist will get back, which used to be great because you could cut and copy their advice into the notes and it gave you a template on which to work, which was really helpful. So it's lovely to see New South Wales. Christine, I wanted to come back to you a little bit because you were talking about allied health. And one of the things I feel incredibly passionate about is the loss of social workers actually doing social work. We have a lot of social workers doing mental health work, and I understand that. But as we get into environments where we have so much poverty emerging, unemployment, those sorts of things, and people having difficulty accessing Centrelink, particularly in the wake of robo-debt, people, particularly my mental health patients, find it difficult to get in the door of Centrelink because of previous trauma, I guess. I'm curious if there's been some thought around community social work in terms of helping people with those basics, the bottom of Maslow's hierarchy: food security, shelter, you know, not having my adolescents sleep in cars, safe place to live, those sorts of things. And with those social determinants of health, what the discussion has been around that sort of thing in the wake of disaster.
Yes, and the answer is, I think we have certainly over even just the last couple of years, I think, become a lot more able to recognise that somebody's mental health and well-being and their ability to access services are kind of linked together, that we need to actually look at what are the circumstances the person is in if we truly want to be able to create an environment where we can help them. Even as simple as how can we actually connect with this person over their mental health? Well, maybe we do actually need to ensure that we are providing a really basic need first. So I think the recognition is there. And I think we are moving from just talking about it to actually understanding what does that mean for a person. So before I can go back to Sarah's example, before I can talk to them about their mental health needs, I'm going to fix that knee, which got injured running because they were coping with something. So it's about put that into what am I doing to help somebody, as you say, access money. How do I get them into Centrelink? How can I help them? One of the things that actually we're rolling out at the moment, and this is in direct response to COVID-19, where we're realising, perhaps take your point and say that somebody who is overwhelmed with having lost their job or lost their income or some other kind of thing that's really threatening their security is not going to be well placed to be helped in other ways. They're highly distressed. So what we are actually doing is rolling out some training across the public service, which is really focused upon how do I, just as a general worker, understand signs of distress in somebody else, and how can I reach across and connect with that. So we're looking at how we can train people in places such as Centrelink or at the front line who can say, I'm dealing with somebody who's super stressed and super distressed, and that's actually to be expected. And I need to know how to do that. And the training is coming from a model which is based on compassion. So it's saying, how can we actually do that whole of person approach? So not directly answering your question about social work, but I think taking that concept and broadening it and saying, how can we actually ensure that whenever we engage with people, that we understand they are people in circumstances, and we have to really try and provide that support in many different ways.
And one of our participants has just thrown in something that was going to be my next question, so I'm really pleased. You know, we had Partners in Recovery, which was a wonderful program, and we certainly have been trying to involve peer workers, and peer workers have a really important place, I think, in this space to enable people to adapt to new circumstances. And actually, I've had a number of my patients with long-term mental health concerns saying that they now feel like experts, and everyone else is feeling what they've been feeling for years. Is there going to be support for peer workers? And I'll come to you, Andrew, in a minute there too, but is there some support for peer workers to try and, you know, manage those activities of daily living and manage things like in general practice? Of course, we find people who can't make appointments and find it difficult to get to appointments and, you know, attend. So I'm just wondering if there's been some thought around peer work.
Absolutely. I think it's one of the most talked about concepts and recognised concepts now is how do we actually take lived experience and bring it into all areas. And I think traditionally we thought of lived experience as being support workers. How do they provide support to people? I think actually if you take somebody with a lived experience of mental illness or caring for somebody with mental illness, they can fit in at so many different parts across the whole spectrum of how we look at service design as well as service delivery. So I think it's actually one of those things we just will not be able to stop. I think it is emerging. There's parallel pieces of work we're doing at the Commission. We're actually working on some peer workforce guidelines. So how can we actually appropriately recognise the needs of people with lived experience? How do we incorporate them into our services? How do we pay them? How do we recompense them? And I think when it comes to mental health, it's also recognising the fact that a peer worker or somebody with lived experience of, say, cancer has got a specific understanding of that illness. And it's interesting, in physical health, we talk about cancer. We don't talk physical health, we talk cancer, and then we talk breast cancer or prostate cancer or whatever. And so if you're somebody who with a lived experience of breast cancer, that's the area you work in. With mental health, I think we're our own worst enemies. We use 2 words to describe absolutely everything. So I think one of the challenges for us when it comes to lived experience in mental health generally, really understanding how do we match particular experience with need, and how do we provide appropriate training and again supervision for people who are working in that space.
Yeah, absolutely. It's all about it's also a little bit about that disease prestige hierarchy, isn't it? There's always so much more money at the top with pink ribbons than there'll ever be for schizophrenia. So it's always that difficulty from the NGO as well as the government sector. Andrew, peer workers in PHNs, we did have some commissioned services in PHNs. Are peer workers going to be something that GPs are going to be able to access to support their patients? So we don't have to go with them to housing and bring up Centrelink on their behalf?
Yeah, look, let's hope so. And I'm really pleased to hear Christine's support for that, because I mean, clearly it starts with government, and then obviously services are commissioned by organisations like ours. But look, that's a direction that certainly we acknowledge the role of social work in particular as well, and in supporting general practices, and just talking about other PHNs. There's some really good examples of work that has gone on around alignment of social work into a general practice, and how a lot of those issues that a GP deals with every day, from health through to employment to housing to, you name it, taking the load off a GP and knowing that a GP is supported. So I think that's increasingly the direction that we want to go in. But it's obviously, it all comes down to our ability to fund these things as well. But I did talk about the non-clinical workforce in social and emotional wellbeing for Aboriginal people, and certainly building capacity through the suicide prevention trial work that we've been doing. So great to hear the government's that's certainly, from a Christine's perspective, certainly indicating that's where we need to move.
We're coming to the end of our, believe it or not, we're coming to the end of this webinar, but I wanted to give sort of the last word to Sarah and say, how can rural generalists who are trying to juggle so many things be kind to themselves and look after themselves at this difficult time? What are some of the important lessons that you learned surviving those 2 intense experiences that you would pass on to someone else at this time?
So I took up running, which I don't know if that's not being kind to yourself, or certainly wasn't a kind thing to do. I've had all sorts of injuries since then. What I found was that, when things were really super, super intense, it was really hard to turn my brain off. And so a lot of the things that I quite enjoyed doing, so whether it was, going to the beach with my kids, or, hanging out with friends, I had this ongoing thing in the back of my head that I could not get rid of. And I found that running was really helpful for that. It probably wouldn't work if you were a really good runner, but if you're a really bad runner, like I was so busy thinking, I can't breathe, my chest hurts, my knees hurt, everything hurts. And I would stop thinking, about all of the other stuff that I couldn't switch off. And I also found that, because I'd get so hot and sweaty and I go bright red in the face. So, and I'd wear dark glasses, and nobody could actually tell that I was crying, because, you can't have a quiet cry at home, because, your inquisitive 4-year-old would come in and say, what are you doing, mummy? So it was a really, and I felt like I was doing something really positive. Like I have taken this into my own hands and I have some control. That worked for me. And interestingly, when this, as we started to get cases of COVID in Australia, I noticed that my own anxiety started going up. Not necessarily for myself, because I was you know, as I said, in Townsville, we didn't have a lot of cases, but I was thinking certainly about my parents. So, you know, they're elderly in their 70s. They weren't listening and not staying at home. I had to yell at them. But again, I took up running really, and it was something that I'd found that I started doing really early in the piece, and it made an amazing difference. So it doesn't have to be running, but you just have to find something that, you know, whether it's a new skill or something where it's all just about you and you're making the decision to do it. I mean, it would obviously be nice at the moment if we could all go and sit on a beach in Fiji or something and drink cocktails, but that's not going to happen. I found this time too actually spending some time with my children outside of homeschooling, because that wasn't fun. You know, just I guess thinking about the things that are important and actually focusing on those. I think the other thing that I've learned is, well, I mean, I've got mentors now. That was a very helpful thing to do, to ring people and say, oh, you know, I'm feeling a bit antsy again. That was helpful. And I guess actually, and I talked a little bit about maturing a bit. So I've learned to not be quite so hard on myself and to give myself a break and recognise that I can't fix everything and that it's okay to be a little bit uncomfortable. I don't know if that's helpful, but, you know, those are the things that have actually made a difference to me.
I think, again, fantastic to hear that idea of, you know, something that is a positive distraction, you know, not just a avoidant distraction, but a positive distraction. Keeping a sense of connection with people who you value, and also doing something where you feel like you're actually achieving something. It doesn't matter whether you're rolling sushi or learning to run or, you know, mastering Lego. It doesn't really matter, but that sense of actually having something, you know, that's a form of kinesthetic mindfulness in a way. And I think that idea of mindfulness in whatever form that takes, for me it's swimming, but, you know, whatever form it takes is really valuable. Thank you so much to the panel. I just wanted to close by reminding everybody that it is utterly understandable at this time to be feeling extraordinarily anxious. And but not only to feel anxious, we don't all feel the same way. Some of us feel angry, some of us feel despair, some of us feel whatever it is we feel. That's just the way it is. But it's really important to seek out support. And I've always been really open about, you know, 20 years ago or whatever, when I've always done complex mental health work, and it's always been hard, and I've always had the patients that a lot of people won't accept. So for me, it was seeking a supervisor, and that was my way of doing it. And I've had a wise psychologist who's taught me a lot about the management of patients and allowed me to debrief for at least the last 30 years. And really, I couldn't do the work I do without her. And I think we all seek out our own ways: mentors, supervisors, Bailint groups, peer groups, learning programs, whatever it takes to find the support to both give you a sense of your own capacity and the fact that no matter how small, you do make a difference, even if you feel like you're constantly not able to fix anything around you. Understanding that what you do makes a difference, because what we know is that the biggest difference that is made to patients is the fact that the doctor does not abandon them. And that's so true in rural communities, that the doctor will be there, the doctor will listen, the doctor will be, you know, the person that you can talk to about your fears and your worries. And, you know, the doctor is a person in the community that the community knows and cares about. I think that's so critical, and that's something you're all offering. I just wanted to take my hats off for everyone online. I know that rural and remote doctors work in some of the most difficult communities in Australia. I know that our international medical graduate colleagues are giving Australia an extraordinary service, and I just wanted to acknowledge how grateful I am for the service that they provide to rural Australia. I think it's difficult, and it's valued by many of us who see the work that you do. And I just wanted to thank you all for the service that you provide. Please remember the Doctors' Health Advisory Service, the Medical Benevolent Society, seeking out the Doctors Clinic, for instance, which provides services, the 10, the Essential Network from Beyond Blue and Black Dog. And I'll actually ask Akron to put that all on a slide and send it out to you so that you actually have the links. But thank you everybody for your comments and questions. Tried to weave those in, and particularly thank you very much to our panelists. So I think we'll close the meeting now and say thank you very much.
Thank you.
Thank you.
No worries.